So welcome everybody. It's very nice to have so many people online today to hear Cindy Turner's presentation on 10 steps to establish a clinical quality registry. So some background to Cindy. Cindy, I actually met with a colleague of mine, Laszlo Arinyi, as we're conducting a project around clinical registries. And so we talked to Cindy as an expert in this field, and her advice was tremendously helpful, and I thought indicated that she would be a great speaker for the Statewide Biobank seminar series. So Cindy is currently the Strategic Director of the SAHMRI Registry Centre. So SAHMRI is, I think, the South Australian Health and Medical Research Institute in Adelaide. And so this is a centre of excellence for registries and registry science. And Sydney comes to this role highly experienced in management and development of clinical quality registries, with over 25 years experience in the health and welfare sector, in the design and development of community-based services. So she has been a registry manager, I think, at the Olivia Newton-John. Is that correct, Cindy? Is that the registry where you were before?
No, it was the Joint Replacement Registry.
Oh, right. Sorry about that. Yes, I wasn't sure what that stood for.
Olivia Newton-John sounds amazing and interesting. But
well, that reflects my bias as a cancer researcher, because I know that she has there's a cancer research centre named after her. But yeah, so you had oversight of establishing automated industry reporting, and you're also overseeing Nestor Clinical Trials project and a patient-reported outcomes project. So you have, a huge amount of experience in this field, and we're really looking forward to hearing from you about the 10 steps that you'd recommend in terms of establishing a clinical quality registry. Thank you, Cindy, again. We're looking forward to your seminar.
Thank you, Jennifer. Lovely to be here, and thank you for inviting me. It's very exciting to talk about my area of specialty, I guess, and passion, and particularly, I guess, to talk to people about establishing a registry before they do it, so that we can get some ideas in there first. So welcome, everybody. Lovely to be talking to you today. Just wanted to start by acknowledging that I'm on the lands of the Kaurna people, who are the traditional custodians of the Adelaide Plains where SAHMRI is based. And I want to recognise their connection culturally and spiritually to the land, and also of those on each of the places where you are today. Thought I'd start off really quite simply with what is a clinical registry. And apologies if many of you have this knowledge and awareness already, but it will help us set the scene. So clinical registries really are databases that operate within governance and structure and systematically collect information on individuals. And we sort of categorise those into 3 areas. So a product registry is someone that's been treated with a particular surgical procedure, device or drug, maybe a heart valve, something like that. The second area is a disease or condition, so diagnosed with a particular illness, so perhaps a stroke, or someone who's received a particular health service. So they've been managed via a specific healthcare resource. Perhaps they've been to an intensive care unit. So clinical registries are observational in nature and observe the practice in the real world without necessarily dictating the care that has been given. I just popped that in there to show you the registries that form the collaboration, which is the Registry Centre, which SAHMRI is a collaboration of about 20 registries that come together with the purpose of sharing resources, knowledge and gains, and working together. Some of those are based in SAHMRI and many are based outside of SAHMRI. And as you can see, they fit into those 3 areas of health service registry, disease or condition, and product registry. Sometimes registries cross those areas, but we try to pick the sort of primary purpose there. So we're talking about clinical registries, but what's the difference then between a clinical quality registry, or a CQR as we call them, is that it's a specific type of clinical registry that systematically monitors the appropriateness and effectiveness of healthcare within a specific domain, but has the real purpose of driving ongoing improvement in safety and quality in the Australian healthcare system. And it's that purpose of driving improvements in healthcare that makes it a clinical quality registry. And so that's critical to their purpose, and they do this by analysing, generating risk-adjusted reports, or the output, and then making sure that they provide those reports in a usable format and a timely manner to the relevant stakeholder who can use it to improve health outcomes. So it's really about getting the right information out in the right format to the people that can use it and make a difference. And that really is, I guess, the most visible work of CQRs, is that output in reporting. 10 steps to establishing a clinical registry. I'd like to say it's 10 easy steps, but not necessarily, but 10 important steps. And this can sometimes sound so basic, but it's so important to the end result. And that is that right at the beginning, that you get a clear and concise agreed purpose for the registry. Often clinical quality registries are started by passionate clinicians or researchers who put in enormous amount of effort and work over a number of years. But having that agreed purpose can really impact the outcome at the end. And it can be more than one purpose, and I've put some there. So some might be just to monitor and report incidents. You might take that a step further and then report the variation in patient outcomes, and then to take that a step further to be a clinical quality registry, inform clinical practice and improve patient outcomes. So getting together, being clear about what the vision is a really important first step. You can always revisit it and come back. Then once being clear and being agreed and having consensus amongst your group, it's really important then to go back and think, now we thought we wanted to start a registry. Is that the right thing to do? And let's review that if this is the right way. Is there a simpler way? A longitudinal ongoing registry is a big commitment in time and resources and data. Is it the appropriate mechanism? Can you answer the question that you really want to do? Can you answer that question around how to improve quality of care, how to impact that? Or would a clinical trial do that and be more suited, or a simple research project? So just worth questioning yourself in those early stages. And then the other thing that I think is really critical to the success of a registry is having the right stakeholders and having identified them very early and involving them in all of these processes and decision making and confirming that purpose. And if you get them on board, then you know that your registry will also meet the needs of all of those stakeholders. Now that can include your clinicians and should include your conditions, can include a peak body or association, as that's an organisation that can help you inform clinical practice. It might be your relevant health services, statewide, national, your hospitals, industry, if it's a product, and also becoming more and more important in registries, as with most areas of research and probably in the work that you do, consumers and community input, and knowing what all of those needs are and that you've got all of them on board early is hugely significant in the success of establishing a new registry. I think it's then really worth sitting down and undertaking a process to assess the feasibility and sustainability of what you're planning to do. So, and we as a centre provide a bit of an assessment tool which can assist people that are at this stage of really going back and questioning, well, is the data going to be available? And are we going to be able to get it at high quality? Can we get the scope and coverage that we need to make this a success? Can we get it in a longitudinal, ongoing manner to continue this registry? Have we looked at the ethical and regulatory considerations? And this is a really interesting topic at the moment, where there is, I guess, a little bit of a shift that clinical registries should be sitting under a quality improvement or quality assurance framework rather than a research framework, and putting that research as the secondary framework, because we all know the complexities of ethics particularly when you're looking at across jurisdictions and for things like national registries. So that's a really important consideration at the moment. Like we talked about, that stakeholder engagement, and then feasibility and resources. And I think what's really interesting is just because something is feasible doesn't mean it's going to be sustainable long term, and looking at what the resources are required and can they be sustained is a really important point. Look at the cost drivers, look at potential funding, determine your funding, what you've got, to avoid having put in a number of years of work and getting down the track and going, you know, we can't keep this going now. So looking at all your costs, getting your funding in place, really important before proceeding. But if you've cleared all those hurdles, you're clear on your purpose, you know that the registry is the right way to go, you've got your stakeholders on board, you're all there, it is feasible, you can fund this, then I think you're on a really exciting journey and time to proceed. And for me, it's really clear that the difference between a register and a registry is the team behind it. I think of a register as the spreadsheet or a database. People can collect data, have it in a spreadsheet, have it in a database, but unless you have the team, the project management to implement and roll out and nationally, the clinical oversight and input from your clinicians, stats and analytics teams, so critical getting them on very, very early, even when you're deciding, you know, your research question and designing your ICT system. Building that team, whether you build it initially voluntarily through your governance, or whether you build it in your budget and your recruitment, or both. I think for me, that is the difference between just collecting data and having it in a register. This is what will make your registry. We talked a little bit then about governance. So this is critical complying with Commonwealth Government's framework for clinical quality registries is good governance. Recruiting that expertise we were just talking about onto your governance group early in the process, and including in there an expert in registry development, which often gets missed, but enables you to avoid having to kind of relearn all the mistakes that other registries have had the opportunity to learn from. But that registry development and operations, bringing all that expertise into your governance, and then, like I said, it might also be in your operations team and your employer, but having that kind of oversight, I think, smooths the road to implementation. Having done that, a good time to go back, review and define the scope and the rigour of what you are planning, looking back at the purpose, ensuring the scope of what you're able to do is going with the resources you've got, the workload you've got, the quality control, reliability, all of those things are going to enable you to answer that question that you had or undertake that purpose. But it can also help identify any risks that might come up so that you can mitigate them early. So being clear about your scope, if it's national, the amount of data you want, the resources and quality you've got to do that, really important. And I guess that's the thing about registries and clinical registries is they are known for the quality, accuracy and completeness of their data, and that's what makes them so valuable. Defining the data set, patient outcomes and the target population, this is one of the most important things, and developing the minimum data set. And this is kind of my, I don't know, non-stop repetitive line here. It is the minimum data set needed to answer the research question. Working with passionate clinicians and researchers, it's my common experience that everybody wants to collect everything possible in case that you need it. But to establish and maintain and sustain a clinical quality registry, we need to be really aware of the burden of that data collection and keep that to a minimum. Everyone, everywhere, in hospitals, in health, are busy undertaking an awful lot of work. And so we need to be really clear that if you can make a registry not an enormous burden, it has a greater chance of succeeding and being successful in the completeness of its data. I also think we have such a responsibility that if we're collecting someone's data, then we should use it. And we shouldn't be collecting it because it might be interesting to use later one day. That's not what a registry should be doing. So what we want is a complete and accurate data set, and then using that, maximising it later by adding projects, various research activities to that core data set. But by keeping that core to a minimum, you haven't risked, I guess, the success of your registry. So this is really hard. We have this conversation repeatedly, and people still come back to us with enormous lists of data that could be useful that they want to collect. So it's a hard thing to narrow this down, but it's really worth doing that in the beginning. You can add data fields later. So you should never think, oh, if we don't get it now, we won't ever get it. But that should also be limited. If you do the work with a broad team and with the experts to define the minimum data set in the beginning, it's unlikely you're going to miss anything critical. And this is where I think having your statistician involved early helps you determine that you're getting the right data that you're going to be able to use. Extremely valuable. We know that people like to have, free text fields, things like this. But when you sit down and you talk to your statistician, that's really key in going, well, how usable is that going to be? But you can add data fields later, but keep that really, really limited and make sure your governance group are agreeing that. And I think don't ever think that you can't seek additional expert advice, even at this early stage, or having someone else who's experienced in registries review what you plan to collect. It will help you determine that it is going to answer your question and that it's feasible to collect it. So putting that time and effort in early is very worthwhile. Developing a study plan or protocol and documenting this really early ensures that everybody understands early what you're going to be doing, what your intention is, and the how that you're going to do that. It will enormously assist with ethics and governance applications. And I had a really interesting discussion this morning with someone who was really talking about maybe not calling this a protocol. If we move away from the idea that research is the primary aim, excuse me, and that quality assurance is the primary aim and research is the secondary aim, that maybe this is more a plan or a compliance document. But either way, whatever you're going to name it and how you're going to use it, getting it all down in writing, talking through the processes really, really early is valuable. And consider publishing your protocol as well. I think that will enable you to receive other feedback as well externally. And, I come from a project management background in health. Developing a plan, literally with your timelines, allocating your resources, putting in your milestones and documenting this. This is, and it may not be everyone's area of expertise, but it's why you need project management on your team. It's really critical to keeping you on track, but it also enables your governance or advisory groups to help you out if you get stuck and something's not working, because if you're reporting against this, everyone will know we're not meeting this milestone. Why not? What can we do about it? So for me, I think having a good project plan with all of those details in there means you're not doing it alone, and it makes a good use of these experts that you've brought in to your governance team to ensure your success. And so if you've done all of these things, you're implementing your project plan, you're going to have a clinical quality registry somewhere roughly in the timelines that you thought you would, using your resources. And they sort of sound quite simple, but if you miss one step, and I've met with many people who've been working down the track for a number of years and have missed a step in this, it's made it so much harder to go back afterwards. And and that it's really important, something like about the next 10 years of your life, I think, for a good clinical quality registry before it's up and functioning and running and doing all the things you hoped when you first got together that it would do, but nonetheless worthwhile. So I guess then I wanted to take this from the point of, well, you might have established a registry. Someone else has established a clinical quality registry. And we talked about the difference between a register and a registry. So we don't want this data sitting somewhere on a spreadsheet, and we don't want it siloed. The biggest thing about CQRs, or making a registry a clinical quality registry, is that we're required to generate benchmarked reports on the appropriateness or the effectiveness of the care, and they should be risk adjusted. So it is these outputs or reports that are the most visible function of CQRs. They inform national and international benchmarking. They identify significant variation in processes of outcomes. So it's no good whacking really hard and building an amazing registry if we're not getting what we're finding out to the people that can make a difference. And so it is participating health service organisations. And we all know if we can get data back and reports back to the people that have put in the effort to collect it, then they have more interest in contributing the data and seeing the direct value for them. And that really does need to be timely for them, but also jurisdictional health departments, statewide level departments, or area level health departments, private and public, really helping to maximise the value of what is happening. Funders, so they know the value of what you're doing. Clinicians, absolutely. You know, we like to look at this, that clinicians own this data in a way. It's owned by multiple stakeholders. But if you're getting clinicians to contribute this data in an ongoing manner, maybe for their career, then it's really important that we get back to them the value from this, that they can make clinical practice change. Clinical colleges or peak bodies also serve a really valuable role here in actually being able to change clinical practice guidelines for their members, education opportunities, and getting that information out there to really make a difference. And of course, researchers, so that they can undertake further projects outside of the core of the registry work. So I just wanted to go through some of those output or reports and what they can actually do. So publicly available reporting is really important. So it's generally aggregated clinical and CQR findings. It reports on national trends in outcomes and patterns of practice. Good practice would also ensure that those report findings are relevant to and consumable by consumers or the general public. So making lay reports available, and that then will help I guess, informed decision making by community members, consumers, working with their clinician to be actually saying, well, I understand these reports. What does this mean for the decisions you're making for my health? Really important, but also enables whole of policy change and development of clinical guidelines. And routine provider reports, so if data's coming in from a hospital or from an area, from an individual, really getting data back to them. Now, generally what this means is, and when I say their frequency, that's appropriate to whatever the focus of the CQR. It might be on some particular health issue, 6 monthly reporting is useful. It might be for others that change is much slower and an annual report is enough. That needs to be appropriate, and we don't like to set a timeline on that, but making sure that it's risk adjusted to the unit or the jurisdiction or the private hospital group. These reports usually don't identify clinicians and patients. So you might have a private hospital group, a large group that's like national, and you are able to provide them a benchmark report which tells them how their hospital group is going against national comparators. And I think those sorts of reports are enormously valuable to hospitals and jurisdictions, and again enables policy change. And there are examples of things in there where reports might have gone to a hospital group and they might see that, you know, their revision rate could be improved. Why is that? Well, maybe some of the prostheses or implants that are being used are not the most successful ones, or they've been identified as such. They can implement policy change around not using those poorer performing prostheses and improve their patient outcomes. So really important level of reporting, but right down to the unit level. So a particular unit, an intensive care unit within a hospital, can look at their own risk-adjusted data, again comparing them nationally, and can then look at how they can, right within their site, improve their own outcomes. Now, we had an example of a particular clinician having a higher than expected infection rate, but only at one of the hospitals that he was practicing at. And so it enabled him to explore that further, which actually came down to others having a higher infection rate there and being an air conditioning unit problem. So, you know, that's quite a specific example, but that unit level reporting does enable a unit to look at how they fare against national comparators. And then what we call ad hoc reports, which is really being able to report on requests. Now, that might be a jurisdiction, it might be a unit, or it might be an individual clinician wishing to request a report. So an individual or a unit, or like the one I just talked about, that perhaps had a higher than infection rate, can drill down and get further data on that topic relevant to them. It's not identified by patients or clinician, but enables them to further explore an area that they can work on and improve change. So one hospital, for example, couldn't request another hospital's data, but they can request their own and get that national comparator. So again, really valuable when we're talking about change in practice. I mentioned a little bit briefly before about the importance of getting data back to clinicians. As frequent, often registries are able to do that in real time on dashboards or as needed in order to answer that question. But getting those out and enabling clinicians to look at their peer group. They're always a competitive bunch out there wanting to make sure they're performing as high as possible. Looking at that, again, narrowing down any areas where they might be able to improve that work. We had a really good example of this in the Joint Replacement Registry, where a surgeon was looking at his own revision rate and thinking it was higher than he wanted it to be and higher than his peers. And after meeting with registry and clinician teams, he was not always, in fact, rarely replacing the patella or the kneecap when he undertook a joint replacement replacement. So he changed his practice and began replacing the patella and had a drop in his revision rate and an improvement in his patient outcomes, and was able to track that through and was very happy for, you know, like that to be shared as a case study. So a real example where a change in practice brought about a direct improvement in patient outcomes for him that was trackable and evidenced. So, you know, we shouldn't underestimate the value of individual reports out there. So I guess that kind of fits within what we would call the core purpose of a registry. Like I said, the most visible output is those reports. You've got to get them to the right people in the right format that works for them and in a timely manner. But then if we really want to maximise our clinical quality registries, it's then how we also work with them around the secondary purposes of research. And so we also hope that our CQRs are able to provide data for approved purposes, such as secondary use for research. And there's always a number of approvals to be obtained to do that. and most CQRs will have a formal data request and approval process in place in order to request ad hoc report or data. And not all registries provide like line level data. They may well provide it aggregated or in a report. That varies between registry. I guess it's also really important to note that particularly some of our smaller registries can be restricted by their own limited resources in how much and how often they can provide ad hoc reports out for secondary purposes of research to external research. It's a good thing to keep in mind. And notwithstanding all of that, the need to have the appropriate approvals in place. Where it's relevant, we need to acknowledge that in the end, the CQR makes its own determination on data it releases and how it does that. Often that can be found on their websites in their policies that refers to that, but in the end it comes down to whether they release it or not. And there are often publishing and authorship requirements that you need to acknowledge the registry. Many clinical quality registries will insist that you have a clinician on your research project. Partly that's because it is clinicians that have contributed their data and so that they are included in that, but that you have a clinical view of that. So there will likely be publishing and authorship requirements, and many registries also will have in place some time restrictions. So you may be provided data, and while that data is with you, it's not provided elsewhere. The same data is not, but there'll be a time restriction, and you might be required to have a draft publication available to them in 12 months. And which doesn't mean you can't also apply for extensions, but I guess what they're saying, if we've given data to you and you're not going to use it, then we want to be able to give it to someone else who can undertake that research project. So it is about also, you've got the data, they're not going to give it to somebody else in the meantime, but if you don't use it, that will be time limited. I always think the best thing is, if you're wanting to undertake a piece of research, meet with someone from the registry, chat to them, talk it through, get them on board before putting in your ad hoc request. The kind of research that's suited to clinical quality registries, data linkage projects that might link a registry data to another registry. An example of that is, linking data from a health service registry or product registry to a rehabilitation registry and getting a different, a longer term output, or biobanks, MPS, administrative data, hospital separation data. Any of those. The other sort of growing area in Australia is around registry nested trials, probably a bit more happening internationally than here. But, as an economic and efficient way to undertake a trial that is really of growing interest. So I guess if you kind of imagine that a registry has a minimum data set of very complete and accurate data, but in order to undertake a trial, and there have been some that have been around, fluids used in kidney replacement or anticoagulants used in joint replacement, you are able to have a time period, a 12-month time period, a different number of sites or hospitals where you collect those additional pieces of data and add them to the core data already collected by the registry. And it means you're not having to recollect all of that standard data, and you can undertake a trial quite efficiently and effectively with really good recruitment in a much shorter period of time. And so a lot of work being done to expand registry capability to do that and resources to do that. And then, of course, research projects where you might want to be looking at a specific cohort or a specific period of time or even a geographical location. And I heard this term the other day, sprint audits, which I really liked. It attracted me to it because it comes back to that point of saying you've defined the minimum data set that you need and you're collecting that, but you really, really want to know about this broader project, and you can do it quickly in 12 months with a couple of hospitals who are committed to doing that extra burden of data collection for you for a period of a time to get the answer to a question, and then they don't have to maintain it beyond that. So I thought it was just a really good way of saying we can have this extra burden for a period of time. We can't maintain it forever, and it'll enable us to answer a question quickly. That's a really interesting concept there. And I guess I wanted to give you, I've given you a couple of little examples there along the way, but this example, Rosa is the registry for senior Australians, and just talk a little bit about sort of the impact they've been able to have. Rosa's speaking as a relatively new registry, only commenced establishment in 2018. But in, those first 4 years, it published 62 peer-reviewed manuscripts and delivered 8 reports for the Australian government on the Commission into Aged Care Quality and Safety. So we're really able to have input at a really important national level very early. They've been able to focus really on national priorities and high burden areas. We all know how aged care, I guess, is in all of our minds and media lately. But then they're able to do projects in addition to that around the experience of individuals perhaps with high burden diseases, or including conditions that are often understudied in the aged population in those particular settings. Really significantly contributed to policy change, to developing indicators of quality and safety for aged care, and they are now extensively used by the Australian government and were by the Royal Commission into aged care. So really important work quite quickly. I guess I just wanted to add then that most CQRs will want to work with you, but can be limited by their own resources to undertake, I guess, the core components of their work, and research many times being like the secondary component of what they're doing. And I guess that's like mostly, I guess, what I had to present to you, but maybe I'll hand over to Jennifer to see if there are any questions that people might have.
Thank you, Cindy. That was great. We do have quite a lot of questions actually coming through the chat, so we might run through some of these questions first, but if people do want to ask additional questions, yeah, feel free to put up your hands and we might sort of go back and forth between the chat a little bit. But the first question is from Danielle Wade, and she has 2 related questions. You spoke of the shift away from an ethics framework to a QI framework for these types of registries and mentioned research in step 8. Can you explain how this would sit with this shift? So that's the first question.
Yes, it's challenging for many, and positive and logical for many others to look at this shift. I think what's really important is if we shift to a quality assurance framework, we don't lose the really important research component of registries, but it's around that sort of core function of registries being for quality improvement and doing that under a quality improvement framework, and then having ethics approval for research projects that happen in addition to that. And the complexity often of setting up a clinical quality registry and ethics approvals across jurisdictions and everywhere is enormous. The drain on resources is enormous, and time delays. We're undertaking a review at the moment of a pilot registry, and the first meetings and discussions happened in 2017. We're now reviewing the pilot. So we need to speed that up in terms of our resource. I'm not sure if that answers that question there.
Yeah, so I think this second question is kind of related. So it's really, if the registry has a QI focus, is there a role for the researcher to request access to the database depending on the governance framework of the registry?
Yes, absolutely. So, and I think that's my comment, we mustn't lose the research focus. And so, yes, so then those research projects and requesting that data are done under ethics in your standard way a research project is. And I think it speeds up both of those things happening. So really important that we don't lose that ability to request the data for research.
Thanks. And Danielle's saying that, yep, that's been mostly answered, and I think she's interested in the consent question. So yeah, we'll definitely get to that. Thank you. So we've got a couple of questions from Imesh, just asking about whether registries can be created retrospectively, or do they always need to be about prospective or real-time data?
I would say generally, yes, is future focused rather than retrospective, and it's real time. That's what makes it a clinical quality registry. Having said that, registries that are set up using real-time data and current data can also add to their database retrospective data, which kind of builds up the amount of data for comparative purposes. And sometimes, you know, a pilot or studies have been done and there is retrospective data there, bringing that in, you know, adds to the sort of quantity of the data. But really registries are about real-time practice improvement. Yeah.
And Amesh is also asking, how does a registry differ from clinical outcomes research?
I think mostly in the nature of the longitudinal ongoing nature of registries. So if I'm understanding that correctly, you can still undertake a research project on clinical outcomes, but I guess that registry is established, you know, where registry has been going 20, 30 years and build that body of knowledge, whereas you might undertake a much shorter term research project, but also lots of overlap there.
Thank you. We've got a popular question here from Tessa. Can you please speak to requirements around patient consent? I imagine this is there's quite a lot of different components to this.
Look, there is, and registries do vary in this. There are registries that are, you know, individual consent opt-in. There are registries that are opt-out. There are some that are waiver of consent. And I mentioned that we're undertaking a review at the moment. This registry has in place all three versions of consent, so a kind of multiple approach. There are varying views on that. Yeah, I guess it needs to be appropriate to the particular method of collecting data and what it is that you're doing. It's such a funny thing with patients. You have so many consumers that will be saying, well, of course you can deal with that with my data. I assume that you would be doing that anyway. You have others saying, what do you mean you have my data? So I think in the end, it's all about, you know, trying to answer all those questions and protect individuals at the same time and still enable us to have that work on outcomes. But yeah, yes to all sorts of those options.
Wow, that's very, very interesting. Amesh is also asking how are conflicts of interest managed around registries? I imagine that's quite a broad question as well.
I'm not quite sure, and Mesh might be able to clarify that a little bit more. Are we thinking then if we have clinicians in the governance bodies of registries, that kind of conflict of interest, or is he thinking more about maybe industry and pharmacy?
I'm not sure. Oh, yes, Amesh, yeah, go ahead.
Yes, my question was because when you are testing a product, there could be, you know, conflict of interest. Even physician could have some relationships with the pharma, or they could be involved in developing a product which is being used for clinical practice. So how are such situations managed?
Yeah, I think that is the value of a kind of national registry that has good scope, quality data, and good coverage, so that if a particular product is being tested within that environment, then the national comparator is all others. So I think it's really important that registries are, you know, report on their coverage and quality of their data and the validation of that. And as we know, all should be declaring a conflict of interest in the design of a product. But if the comparator is against all else, it should help alleviate some of that. Yep.
Thank you.
So I actually had a question kind of following on from that, whether, I mean, given, you know, as Umesh says, sometimes there might be these conflicts because we are talking about, you know, particularly in terms of interventions, there's financial implications of these. Have you ever seen issues around difficulties of actually implementing or, you know, recommendations that come from registries where perhaps some of those messages might not be welcome to all of the stakeholders?
Yes, absolutely. Like that's true. So there are some, if we go back to that purpose and setting up that governance and answering those questions really early, I think that's really important. So if you do that and you determine right back at the beginning that you're going to be reporting to the TGA, or you're going to be reporting to this clinician group, or you might put qualified privilege in place to protect the identity of individual surgeons, because that enables surgeons or clinicians or whoever to feel confident in all putting in their data, good, bad or ugly, and knowing that they're not going to be identified, then you also know that you're actually going to have more input and be able to work on those areas of variation. Like there are many other countries, and UK is one of the ones that have tried, you know, identifying clinicians. We know that it can then impact on the quality of the data that's input, how that is managed. So having all those stakeholders on board in the beginning, determining how you're going to doing that with everyone on board makes it all much easier in the end. Or, you know, the Joint Registry is another example. A report on each prosthesis identified, named, and they do that in conjunction with industry. There is no way industry can influence that, but that's been happening for many years with the industry on board. Were things like that controversial when they first started? Absolutely. The same for clinicians. So qualified privilege does provide good protection for clinicians and helps avoid some of that. I'm not sure if that helps answer that.
Yes, no, definitely. Now, if other people would like to put up their hand and ask questions, please do so. I've just got one other question. I think what I was impressed about the 10 steps is how much work is done up front and then you apply to ethics. Does it ever happen that ethics come back and sort of say things like, oh, why aren't you collecting this data? You know, and how do you deal with that?
I don't know if they so much come back and say, why aren't you collecting this data? Because I don't know that anyone misses data. In my view, if they collect more than they need. But yes, they will definitely come back, particularly around consent. And why are you applying for a waiver of consent? What are you going to do this? How are you going to store your data? How is going to be transferred? All of those sorts of things. And I think it is important that you do that work first. And it's important if you have on your group experts in running registries, then you will have answered those questions in your protocol or plan before you put it to ethics. And so that's why I think it's worth doing all that first. Because if you put into ethics first and you haven't answered all those questions, it's really hard then going back afterwards. So I'm very much for putting the work in first, bringing in those with experience that can advise you before you put it in.
Sounds like very good advice. And I guess, yeah, look, we've still got time for other questions. So if people do have a question, please raise your hand, put it in the chat. But maybe just in the meantime, because this is a kind of a biobanking talk, I wondered whether you could give us some examples of, for example, where clinical quality registries have collaborated with a biobank and how that's kind of added to the registry. If you can think of any, you know.
Yeah, possibly my experience is we've tried to do that and put in applications and perhaps not yet got the funding, but where there's really valuable ways of doing that was around, you know, a surgical procedure registry and infection and management of infection, you know, which can be like have a devastating impact. This isn't a project that has got up yet, although I know there's very dedicated people that will continue working on that. But that was very much around, further information around infection that might help change policy. And that can be in all sorts of things, in terms of something like infection, where it's literally, skin to skin time in surgery, pre and post antibiotics, different metals and materials used in prostheses and those sorts of things. So that was certainly a really important project that hasn't yet got started, but hopefully will soon.
Yep, I can see that. That's a good example. I have Danielle's coming back to her question about whether there is a shift from an ethics framework to QI. Would I think that's probably the researchers be applying to ethics, or would an institution's mechanism for confirming QI activities be the appropriate avenue? And then does that have impacts on your comments research?
So
I think
they is referring, sorry,
Danielle.
Clarify. They is, I guess, referring to the people who are starting the registry. So not the researchers like down the track once the registry's in place, but those who are trying to get it up and running.
Yeah. This is still an area that we're moving to. We're having a discussion this morning going, we really need a step-by-step of how this will work going forward. It may be that there's still an overarching ethics approval for the registry as a whole, but every time you go into a different hospital, a different jurisdiction and cross the state line, you don't have to reapply. You are then implementing in the hospital under a QI framework, but there is one overarching ethics application. I can't remember the exact number, but in my work in the joint registry, I don't know if there was like 30 ethics approvals in order to be able to deliver a national registry like that. Now, that's not efficient, and nor should it be necessary. So it may not mean moving away completely, but in establishing a registry, maybe having that one overarching ethics and then using a quality improvement or quality assurance framework after that.
Yeah, that's extraordinary, isn't it? 30 ethics applications, you're right. That's not where we should be aiming for.
No, and then you would all know the resources then into reporting and updating, and every time you make a change, an enormous amount of resources that could be better directed.
Yes, very true.
We would all know that. I'm not
yes,
saying really
I know. Does anyone else have any other questions? I think we might just close it there. Thank you so much, Cindy. That was a fantastic talk. We had wonderful turnout, and I'm sure many people will enjoy this talk once the recording's available on our YouTube site. So thank you everyone for attending. Thanks so much for the great discussion. And yeah, we really appreciate you joining us today and telling us about registries, because they're obviously such an important tool in terms of patient care and ensuring ongoing improvement. So thank you for your work and thank you for your presentation.
Thank you. Thank you for having me. Enjoy your day, everyone.
Thanks, everybody. Bye.